Let's go text Carolyn.
SIDK, what does that stand for?
Signs of internal derangement of the name.
Thanks. I didn't know either.
I'm trying to think. I think just
It's there. It's there in the notes underneath. But anyway, that's what it is.
yeah.
Okay, sorry to hold you there. We've got the knee and we've got the calf. That's a hell of a lot in 1 hour, but we'll try and cover off on all the important things, yeah? Alright, so what you're seeing there is the player in white is getting a pretty severe injury to the knee. Probably a complete rupture of the MCL and maybe ACL as well. So the ACL, really common. The medial ligament's probably injured more frequently, but the ACL is, as you know, it's the more serious one. It's the one that has the worst long-term consequences for the knee. The posterior cruciate ligament is pretty rarely injured. Sometimes, but not as often as the ACL and not as often as the medial. The lateral, hardly ever, and the small ligaments around the knee, sometimes secondarily to the ACL and the MCL. The menisci get injured a lot, but it's usually a twisting injury when it's acute, or it's a degenerative tear of the meniscus when it's chronic. The patella can dislocate. Which way does it dislocate?
Naturally.
No, that's right. It hardly ever will move medially, or if it's going to dislocate or sublux, it'll go laterally. That's pretty common in younger people, like teenagers, who've got loose ligaments. The patella will dislocate after that. It can stay pretty unstable. It can dislocate repeatedly. It can sublux. And there's some little bone hidden fractures around the knee, but certainly soft tissue is much more common, and you'll see hundreds or if not thousands of knee injuries in your career as a physio. So the really common chronic ones are anterior knee pain, and there's always trying to figure out, is it patellofemoral pain, so is the patella involved, or is it patellar tendinopathy? So So that's a constant thing that you'll be trying to work out is the one or the other. And the third one, which happens pretty rarely, and it's really the only thing that happens on the outside of the knee, is iliotibial band friction syndrome. So with chronic injuries to the knee, it's all about what's going on with the cartilage, the articular cartilage and the menisci, and you've got chondral wear and tear. Chondral wear and tear leads to osteoarthritis. Chondropathies or areas of the knee that are worn out, or divots in the knee, cracks in the cartilage, and so forth. And there are some particular syndromes that happen only in children in the knee that you've got to be able to recognise very quickly. These things go in patterns. So it's really about pattern recognition. And after today, you'll know the pattern recognition for a ruptured ACL. You should never miss a ruptured ACL. It's an easy pattern to recognise. Unfortunately, it's easily missed as well. So hopefully after today, I'm going to show you the way that you'll never miss one, yeah? All right, then we've got the calf. Like I said, there's a lot here today. There's the shin, or the lower leg. So there's shin splints, which is not an anatomical diagnosis. It's a layperson's term for pain in the lower leg. It doesn't really tell you what the pathology is or the anatomy is. And there's three. Two are the most common, and a third that is less common, types of shin splints. One is soft tissue, which is medial tibial stress syndrome. The next one is bone, so it's bone stress, or tibial stress fractures. And the third one is a weird one, which is actually vascular, and that's compartment syndrome. That's actually, the pain there is ischemic pain. Alright, then the medial head of the gastrocnemius is a common site of acute muscle tear. Middle-aged men, they're a regular runner, or they're a runner, or a footy player, and they will tear the medial head of gastroc. Where does it tear? Anyone know? Where's the location? Where's the weak point in that muscle tendon unit?
Is it where the muscle and the tendon join?
Yeah, that's right. So it's the musculotendinous junction, and what happens there, it actually can rip completely across, and you really have a grade 3 injury there, but it's only half of the muscle. So it still can function, even though it's like a grade 3 injury, and that's why it's so difficult. And that's why it recurs a lot too, because it's an unrecognised grade 3. Yeah? And then there is the DVT in the calf. There's another pattern that you should recognise as well, which is like a sudden onset sometimes without any injury, without trauma at all. Post-surgically, you'll see one, like you'll see one in your career, where the calf swells up. The calf swells up, it goes hot, it goes red, it goes swollen for no apparent reason. That's probably a deep vein thrombosis, and that's somebody who's got to go straight to the emergency department. All right, so I'm not sure if I've got the correct order here, that may be mixed up, but these are the cases for the week, and we'll go through the sort of different patterns, yeah? All right, knee OA. Everyone's got some knee OA. If you're an adult, you've got some wear and tear in your knee. But you don't have osteoarthritis until your cartilage is worn out. And the osteoarthritis really is a diagnosis made on X-ray. When you do a plain X-ray of the knee, and look at a straight AP view, and you see a narrowing of the joint space where the cartilage is worn out. With that narrowing of the joint space and the wear and tear of the cartilage, these surfaces become roughened, and you start to get grinding in the knee. Yeah, grinding, clicking, popping, clunking, whatever sort of noise you want to think of, or the way you want to describe it. But what we call that in general is crepitus. or noise in the knee. Now everybody's knees click and grind a bit, you know, as you squat down. I'm not going to attempt it now because it could cause an injury. But if you bend your knee or squat down suddenly and it goes pop or click, you know, everyone's knees do that. What happens with that is that could get, if that's painful or if it's becoming progressively worse and the grinding is associated with other symptoms, then we start to take notice. But a lot of people complain of clicking and grinding in their knee. It's just a normal sort of thing and there's nothing too much to worry about. It's only when it's associated with other symptoms, pain, swelling, giving way of the knee, locking of the joint so it stiffens up and you can't move. Now, well, when Phil and I graduated as physiotherapists, the most common sort of knee surgery was a meniscectomy, a medial meniscectomy, where the orthopaedic surgeon, there'd be a torn meniscus, and the orthopaedic surgeon would take the meniscus out, pretty much take it out, remove it completely, and it was thought, well, that's the end of the problem. Actually, that was the start of the problem, because what the meniscus does in the knee is protect the joint. It's the shock absorber for the joint. So the more meniscus that you remove, the more shock will go through that joint. So people who've had, and you'll see them, you know, when you start to see people with OA, they've had knee surgery, they've had a medial meniscectomy, or they may have had knee arthroscopy, they've had different procedures done on their knee. That is the beginning, like the end of that knee, because the more cartilage that you take out, the more protection that you take away from the knee. And they may have had a really bad previous injury to the knee that they knew about, or they didn't know about. Lots of people are walking around with ACL deficient knees and they never had it diagnosed, they don't even know. So they've got this instability in their knee that's causing that extra wear and tear. There could be biomechanical reasons why somebody's knees wear out faster. There are, you know, there's a sort of genetic link. There's not a direct genetic component. But we really don't know why some people get spontaneous sort of osteoarthritis in the knee and others don't. These are sort of obvious reasons, but some people just get OA in the knees. We think it's actually a disease more of inactivity than overactivity. So it's the overweight people who don't exercise much. It seems to be that they tend to get osteoarthritis of the knee, you know, even if they haven't injured their knee before. So one of your roles as a physio is to keep people active, keep people moving their joints, and there seems to be some protection against OA with activity. Usually the medial compartment wears out first, and the typical deformity with that is genu varum or bow legs, right? So bow legs is the picture up the top there. The knee is in a varus deformity because the medial joint line has, the space is gone and the knee is wearing out on the inside and the tibia starts to drift inward, yeah? So you'll get, you know, this deformity, which is really typical of advanced OA. Swelling, stiffness. The worst thing is morning stiffness. So getting up out of bed, those people with OA in the knee, that's when they feel their knee the most. They hobble, they limp. And, you know, because cartilage, I guess you could define it as a soft tissue. Remember we were talking about what's the behaviour of soft tissue versus bone. Cartilage is kind of in between. So in the morning it's really, really stiff. Person stands up, they start walking around, it warms up. They feel a little bit better. It can hurt later on in the day. The more weight bearing they do, and taking weight through joint surfaces that are compromised, the more pain they get. So walking is bad. They will immediately start to get muscle atrophy. Okay, which muscles will atrophy? The quads will go first, and the VMO will go first. So the VMO is the first one you tend to lose when you've got any kind of knee pain. They'll get atrophy in the glutes, they'll get atrophy in the calf, but the quads is the thing that you see, and the thigh just looks really skinny. The knee looks big, and the thigh looks skinny. It can be a bit of an optical illusion because the quads are so skinny, the knee can look huge. And you've got a variable amounts of swelling. Chronic OA doesn't have a lot of swelling. There are certain types of inflammatory arthritis, like rheumatoid arthritis. Have you heard of that? Where swelling is a really strong feature and it's very inflammatory. But OA, it's not really that inflammatory. A lot of it is mechanical. It's the pain, it's the stiffness, it's the clicking. Now, when cartilage starts to wear out, pieces can flake off and float around in the joint, and that's called a loose body in the joint. Loose pieces of cartilage can float around in the joint. So little flaky bits fray off and float around in the fluid in the joint. And those bits can get caught and cause some momentary catching pain in the knee. If there's a lot of loose pieces in the knee can actually lock up and jam so that person can't move their knee. A locked knee actually literally means that the knee's stuck, that person can't straighten their knee or they can't bend their knee, and that's a locked knee. That's usually when there's a really severe meniscal damage. But more commonly, there are these mechanical symptoms in the knee. So that's the catching pain, the locking, jamming, however you want to describe it. But these come under the umbrella of mechanical symptoms in the knee. So once you start to get mechanical symptoms in the knee, that's kind of irreversible. That person is starting to talk about, getting something done because their function is so badly affected. The knee is locking, catching, sharp pain, maybe even giving way. The knee can give way when a little piece of cartilage gets caught in between surfaces, and suddenly, the muscles just switch off and the leg gives way. That's called giving way. That's giving way due to intra-articular or internal derangement. It's not necessarily giving way because the knee's unstable, but it's different. The giving way with instability, like when you've got a ruptured ACL, is quite different to this. Alright, so there's another picture of the varus deformity. So, you'll see thousands of images and diagrams of what the knee looks like inside when the cartilage is worn out. So you get the loss of that smooth, white, shiny, hyaline cartilage surface. It wears out bit by bit down to bone. The surface of the bone becomes sclerotic, or it gets this polished. It's called eburnation or sclerotic. So the subchondral bone gets really hard, and you can see that on an X-ray as well. So on the X-ray you see the loss of cartilage, you see the sclerosis in the subchondral margin of the bone, and because there's so much pressure on the bone, you get subchondral bruising and cysts. Subchondral cyst is more like end stage of osteoarthritis. I'm not sure I can do anything about getting that, you see that a bit better, but can you see it on your picture maybe? Alright, so there's an X-ray down the bottom showing varus deformity. The medial compartment wears out first. And then the knee looks bigger because you get spurring. The body tries to build up the knee, like it puts on more bone, and you get this bony spurring at the margins of the joint. And if you look at the X-ray, it looks like little spikes of bone at the edge of the joint. That makes the knee the joint becomes hypertrophy, the quads become atrophy, yeah? And then the knee itself starts to look really huge in relation to the leg. So the muscles are going down, the knee's going up. Extension lag, what is that? We'll talk about extension lag or quadriceps lag for the rest of your life. Yeah? Who can tell me what it is?
Isn't it like the test of the quadriceps? So you put a fork on and then kick it up.
Good. So what it is, that's probably a quadriceps lag. In osteoarthritis, people lose range of motion and they lose their full extension. So they can lose range of motion, their passive range of motion, so their knee is stuck in about 10 degrees of flexion. You try to straighten it and it won't straighten. Yeah? That's extension lag. And your answer is correct about quadriceps lag is an active loss of extension. So that's when you can't actually actively extend your knee because your quadriceps aren't working properly. But in advanced OA, there's always a loss of range of motion. And it's the loss of extension that is the biggest functional problem, because you're walking on a bent knee. Yeah? You're not walking with a normal gait pattern. You're walking on a bent knee. That not only hurts the knee, but it hurts the hip, it hurts the lower back, and starts to cause all kinds of other problems. So the clicking and the grinding can become worse, the deformity, the weakness. Okay, the hypomobility or stiffness. The opposite of hypermobility is hypomobility or losing movement. So they lose extension, they lose flexion. They start to be unable to go downstairs, get in or out of a car because they can't bend their knee enough. They can't step over things because they don't have enough knee flexion. You see the joint space narrowing on the X-ray, and when you ask, there'll often be a man used to play footy for many years. Lots of people who play sport create wear and tear on their joints. And in this town in Melbourne, all the men who played AFL as a kid, they got problems with their knees, they got problems with their hips, O over the hip and O over the knee. There's a lot of reasons why Melbourne is the knee surgery capital of the world. Because of AFL, because of the lots of ACL injuries, and because we're into these high impact sports. AFL, netball in particular, there's heaps of ACL injuries in netball and meniscal injuries in netball. So that's why Melbourne is a real hotspot for knee surgery and knee reconstruction surgery. But we're lucky that way, and we get to see a lot of knees. Okay, the treatment for osteoarthritis. The first treatment should be conservative treatment, not surgical treatment. So you've got to address the impairments. The impairments are the muscle weakness, the lack of range of motion, yeah? So get people going on quadriceps exercises in particular. Gluteal exercises, really, really important. Gluteus medius, really, really important for stability of the whole lower limb. The calf, the hamstrings, and there have been a lot of studies, and Dr. Kim Burnell at Melbourne University runs a very vibrant group on osteoarthritis of the knee. So there's a lot of evidence backing the use of physiotherapy as your first course of action for somebody with knee osteoarthritis. So there's range of motion, strength, gait re-education. We can use bracing for the knee to help control the deformity. We can't reverse it, but we can try to control it. And there's a role for foot orthotics, because as the knee deforms, you're getting a sideways movement of the foot. So getting some foot orthotics in can be helpful as well. Now lots of people take fish oils, they take glucosamine and chondroitin, they take green tea, New Zealand blue leaf mussels, extracts, turmeric extracts, you name it, there are lots of those things around. The evidence behind those things is not solid, but there seems to be some, kind of very low-level evidence for fish oils and this combination of glucosamine and chondroitin. It depends who you ask if they believe it or not. Most people on the medical side don't believe any of these supplements work. Other people swear by it. But you'll meet people who take glucosamine every day and this glucosamine and chondroitin supplements. Fish oil as well. There's sort of these things that you've got to be educated about these things, do your own research and see if you believe it. But a lot of your patients will swear by it. Then there's the role of the actual pharmaceutical drugs rather than supplements. So anti-inflammatories, there's no doubt that if you take anti-inflammatories, you have less pain. If you take Panadol, you'll have less pain. And if you take the one that a lot of people use is Panadol Osteo, which is just paracetamol in a slow release form. So the half-life is over 8 hours instead of 4 hours. So they can take 1 or 2 a day instead of taking it 4 times a day. And people just take that all the time just to try and control the pain. Unfortunately, if you take, even with paracetamol, but especially with anti-inflammatories, there are side effects. What are the side effects with anti-inflammatories? Who knows?
It can be harsh on your stomach lining.
You have?
It can be like harsh on your stomach lining.
There are gastric implications because what the anti-inflammatory does, it makes the stomach lining more susceptible to the acid that's already in your stomach. So it takes away some of the protection of the stomach lining, and that is with pretty much all anti-inflammatories. Some of them have a sort of less severe side effect profile than others, but if you take them for long enough, you're risking stomach ulcer or stomach bleeds, and that can be fatal. Like someone can actually die from a stomach bleed. So it's not a small thing to be taking anti-inflammatories all the time. But if there's an acute flare-up, I think it's a reasonable thing to use anti-inflammatories to try and get that flare-up under control so you can get on and do your exercises. But you've got to advise that person they've got to have anti-inflammatories with food, and they can't take them if they've got any problems with their stomach or digestion. All right, there are thousands of different kind of braces, knee supports, orthotics. Heat can be useful in providing some symptomatic relief. So they're pretty much all the conservative and non-invasive things, yeah? Then you get on to the invasive treatment, right? And there's lots of different invasive treatments. There's injections. There's autologous blood injections or PRP injections, which is platelet-rich plasma, which is your own blood. The doctor will take blood out of your arm, a lot of it, spin the blood down to get the platelet-rich part of it in the plasma, and actually take the actual blood out and then inject it into your knee. That's a PRP injection. It's got to be done under sterile conditions. Now, PRP injections are kind of the latest thing, and they're being used for nearly everything. You can have them in your face to make yourself look younger because of the growth factor, supposedly, in the PRP. You can have it in tendon, you can have it in all kinds of different tissues of the body. The science behind it is tenuous. There's still, again, arguments for and against. There are other older types of knee injections, which are essentially like a lubricant, putting more lubrication back into the joint. Hyaluronic acid, which is Syndisk, which is another type of injection that people can have in their knee. And again, look, it depends who you talk to. If you go to a musculoskeletal physician or a sports physician, they'll probably, if they're going to offer you invasive treatment, they'll offer you an injection. If you go to an orthopedic surgeon with knee arthritis, they're probably going to offer you surgery. Sort of thing, if you walk into a butcher shop, it means that you want to buy some meat rather than buy stationery or something else. So it depends who you're talking to, who you're referred to, and what stage of the level of OA that you're at. But certainly, physiotherapy has a really important part to play. It should be your first thing. Address the impairments. People can have the most shocking worn-out knee, stiff knee, terrible on the x-ray, but they can still function very well. And it's really in that, it's about the muscles. It's about how much muscle control they've got around their knee and how much mobility they can maintain or get back. Alright, then if it goes too far, the person's in too much pain and they're functionally impaired and conservative treatment has failed, then the cartilage is completely worn out, so it's bone on bone. And then the orthopedic surgeon will probably offer knee replacement surgery. You can have total knee replacement surgery, where you have a new surface on the femur, a new surface on the tibia, so the femoral condyles are actually virtually cut off. The top of the tibia is cut off and replaced, and usually the patella is replaced. So the femoral surface is now titanium, so they use titanium, so it's a very hard, smooth, long-wearing substance. The tibial surface is a polypropylene type of plastic, a very special type of plastic, and the patella is usually plastic. So this is a total knee replacement, and there's thousands of total knee replacements happening every day. It's one of the most successful orthopedic knee operations there is, hip replacement and knee replacement. You can correct the deformity to an extent. There are other surgeries that can be used where the deformity is really severe, like literally a straightening of the tibia, called a high tibial osteotomy. So that is an option as well. So that's a total knee replacement. Who knows somebody who's had a total knee replacement? Grandparents or whatever. Very, very common, yeah? Now, they don't, there's a big rehabilitation component of this. So when I talk to people or they're asking me about, well, should I have my knee replacement? They go, well, it'll fix the anatomy, but it won't necessarily fix the function. 50% of the result is the surgery, and 50% of the result is the rehab. So people have surgery, and they don't have rehab, and they have a poor result. Or people have surgery, or they only do a little bit of rehab, they don't complete the rehab, or they're not compliant with the rehab, and they end up sometimes worse off. The knee's even stiffer than it was before. And like I said before, people's knees can be a shocker, looks terrible, but if they do the rehab and they do the work, they often can function quite well. They don't need the surgery. Now, knee replacement surgery doesn't last forever. If you're lucky, you're going to get 15 years. With the previous materials, it used to be 10 years. So if you're lucky, you might get 15 years. If you're very lucky, you might get longer. So depending on your age, you might want to delay having your knee operation so you don't have to have another one, because your knee might wear out. So there are all these things to consider. So you can have a full knee replacement or a half knee replacement, yeah? So that's a hemi knee replacement, where only half of it is, the medial side is completely worn out, and just the half done. So that can be something that can be done in between, before you have a total knee replacement. The rehab, you've got to get the movement back, extension, try and get full extension back, whereas it was lacking before. And flexion, range of motion, get the muscles going, get their gait walking. It's elective surgery, so people are often in a situation where they have to wait months, sometimes years, to have their knee replacement surgery. That's an opportunity to do the rehab, start the rehab early. So what we call prehabilitation. The better and the stronger the muscles are before the operation, the easier it'll be after the operation. So if they go into the operation with a really withered leg, with no quadriceps, really, really stiff, it'll be really, really difficult to rehabilitate after the operation. So you have time, because it's elective surgery, do the rehab. Do most of the rehab before, so get it as strong as you can. Now normally it's they're either doing it publicly or privately. They go in, they spend 1 or 2 days, maybe 3 days in hospital, and they go home. They may need your assistance. You may be working in the hospital, getting that person to mobilise their knee, getting them up out of bed and walking so they can go home, or they may go to a specialised rehabilitation centre where they have daily physio and daily rehab before they go home. So the main thing is function, mobility, being able to get up and walk on the new knee. The pain should be pretty much, after a few weeks, the pain should be gone. They can be very, very successful in relieving the pain of the knee. And you've got to manage the scar as well. There's usually a big scar in the front of the knee, so you'll look after that as well. Make sure it doesn't get infected, and make sure you have a mobile scar so the scar doesn't get tethered and stuck. Alright, so here's the big one, the ACL. Okay, usually when you're talking about ACL, you're talking about a complete rupture. So it usually tears mid-substance, so through the middle. And the mechanism is variable. It can be hyperextension of the knee, like this picture down the bottom, but often there's a twist. So there's either a massive internal rotation of the femur and external rotation of the tibia, or the other way around. And there's often a combination of landing from a height, twist, and some kind of movement forward or backward. Okay, and the ACL is ruptured by a dislocation of the lateral femoral condyle on the lateral tibia. So with it, you often get problems in the posterolateral capsule of the knee, posterolateral instability. Now, so typically they'll be running along and they'll be changing direction. They feel something pop in the knee, and they're usually immediately disabled. So it can be very, very painful, so they're writhing around on the ground holding their knee, and usually they realise they've done something very serious to their knee. Look, some people are tough and they pop their ACL and they just carry on. I don't know how people can do that, but sometimes they'll come years later and tell a story. Oh, I was skiing one day and my knee popped. It was a bit sore, and I skied the rest of the day, and it was sore for a few days, and it was fine after that. And then a few years later, the knee's got arthritis. And you go to examine that person and go, whoa, what happened to your ACL? There's no ACL. So it pops, it's exposed to the synovial fluid, which basically dissolves. So after a while, there's nothing left of the ACL, and it just won't heal. Like a lot of things that go wrong inside the knee, it won't heal by itself. So it happens in football, soccer, netball, skiing is a big one, basketball, and I say aerial sports like the ski aerialists. Nearly all of them will pop their ACL. They'll have one ACL, then they'll bust the other one, and then they'll have a reco on the other one, and they'll bust the first one again, they'll have another one. So they end up having 2 or 3 ACL reconstructions. Who's had an ACL reconstruction? Hands up. Well, not that many. I thought there'd be a few more. Who knows someone who's had one? Yeah, plenty. Oh, jeez. Plenty of people. So it's very, very common. You've got to be able to recognise it. So you've got to be able to recognise it by the mechanism. The pain, the whole knee hurts. It's not really localised to one part or another. The swelling will be immediate. Why is that?
So rupture of the capsule?
It's bleeding. Yeah. So the difference between a meniscal injury, or one of the main differences, a meniscus doesn't have any blood. Ligaments have blood, right? So a rapid swelling, the knee will swell before your eyes sometimes, but a rapid swelling within 1 or 2 hours in the knee is a hemarthrosis, or blood in the knee. That's why it's often so painful. And a swelling that happens overnight, so somebody's hurt their knee and it doesn't really swell up till the next morning they look at their knee and it's swollen, that's less likely to be bleeding and just more likely to be just fluid. So that's an effusion, all right? So fluid seeps into the knee in reaction to any injury, but blood will bleed into the knee when there's been a rupture. Something's torn or something's broken and it swells rapidly. So that's a big, big clue that something is torn inside the knee. There's an inability to straighten the knee. There's another telltale sign with ACL. I'll tell you why. You know the intercondylar notch, that little valley in between the femoral condyles? That's where the ACL and the PCL sit in there, right? Now when you rupture the ACL, it tears and it retracts into that notch. And it actually gets jammed in there so you physically cannot straighten your knee. And that sort of inability to actually straighten the knee is a big, big sign of an ACL rupture. So they come in the next day, or you've seen them immediately, swollen, can't straighten the knee. Feels pretty bad, like they usually are very distressed, they feel upset, they may be in tears, they've got a real feeling that their knee is really severely injured, a terrible feeling of weakness and instability in their knee. So if you look on an MRI, which will show us very clearly, unfortunately here not that clearly, but there should be, this is a T1 weighted image MRI where tendon and ligament should be black, so dense tissue like muscle. So there should be a complete ACL and it's a dense black line there, and in a rupture there's just nothing there. It's just space, you see fluid in there, and instead of a dense black line you just see nothing. You can see maybe the frayed ends of it where it's... And people sort of describe, oh my knee, it felt like my knee exploded inside. And if you look at the MRI, it kind of looks like that. The ligament is kind of expanded, spread out, frayed out all over the place. So you see the gap. The other thing you see is the bone bruising. The bone bruising is typical with ACL injury because you've had a momentary dislocation of the knee, and usually the lateral tibial plateau slides forward. That's the pivot shift phenomenon. The pivot shift is when the knee dislocates like that, and the femoral condyle knocks the back of it. So there's sort of a diagram of that there. That's the femoral condyle just getting on the back corner of the tibial plateau, and it'll hit on there, cause a big bone bruise. A lot of the pain in the next few weeks is that bone bruise. You remember last week we were saying sometimes a ruptured ligament doesn't hurt at all. After the initial pain, there's not much pain in it at all. But people with ACL with significant bone bruising, they're still really, really painful. And that's why sometimes the surgeon will wait and not do the reconstruction straight away. The next thing, as that impact happens, is a little fracture, which is the only thing you usually see on a plain X-ray of an ACL, is a thing called a Sagon fracture, which is a little kind of corner of the tibia knocked off. So that's another, if you don't have an MRI, you just have an X-ray, look for that Sagon fracture, which is an avulsion of the edge of the lateral tibial condyle. Right, so they're the clues. Right. The mechanism will give a clue. They'll be walking, if they can walk at all, they're walking on a bent knee. Can't extend the knee. You've got functional tests like try to straighten your knee, they can't do it. Look for the swelling, look for, there might be deformity, but often there's not, there's just swelling. Tight swelling in the knee, which is the hemarthrosis. And then you're going to examine the knee, yeah? So palpate it, the range of motion will be restricted, the quads may be inhibited, but the important ones are you're testing the stability of the knee. And these are the tests for the stability of the knee. The ACL, you know, and you just have to be systematic in how you do that, so you don't miss anything. Usually you do the ligaments first, then you test the menisci, and then you test the patella. All right, the big ones for the ACL, they're all about seeing if the tibia slides forward. So it's the anterior draw test and the Lockman test. You'll be doing these in the prac, yeah? There are other ones, there are fancy ones called the pivot shift, which is a much more aggressive test that tests how the lateral side of the tibia actually pivots and is unstable there. That's a very pretty painful test. There are other ones as well, but you don't have to know all the tests. If you've got these two, the anterior draw and the Lockman, if you can do them well, you'll find the instability. Now the PCL can be injured with a blow to the front of the tibia, or a hyperextension injury, or landing heavily on the top of the tibia, and it'll stretch or tear the PCL. But it's not as common as ACL. So that's the reverse, okay? So you're looking now to see if the tibia slides backwards on the knee. What also happens is the knee will hyperextend. It'll look like it's sagging or hyperextending. So if the person's lying down on the bed, you lift one heel and the good knee will extend a little bit. You lift the other heel and the knee's like a banana, like it's hyperextending. And it's like a sag test. The medial and the lateral. Okay, the medial ligament of the knee is huge. It's massive. It's as big as your hand, all covering the medial side of the knee. So to tear that thing takes a lot of trauma. It's a bad injury if you've torn the medial ligament. And it's in 2 layers, and it's a complex structure that controls the medial stability in extension and then through flexion, all the way through flexion. So you've got to test it in full extension, and you'll be testing one part of it, and then you've got to flex the knee and test it in flexion, you test another part of it. But if the knee is really loose and opening up in full extension, you've probably got a total rupture of the MCL and the ACL. So when the knee's really unstable in full extension, you're in trouble. You've got those probably got those two ligaments torn.
Sorry, I just want to clarify something. Earlier you said the most common injuries are ACL and MCL. So you said, but just now you said MCL is very strong.
Very strong. It's a very strong ligament, yeah.
But then why would it be that MCL is more prone to injury than LCL?
Because there's a lot of mechanisms where you, in football, where you get pushed this way. That's a common mechanism of injury, and the MCL will tear. And skiing, right? So the MCL is really common. I reckon they're as common as each other. Let's put it that way. You had to have a bet each way about that knee's really unstable in full extension. It's either MCL or ACL or both. Now, the McMurray's test is so the meniscal tests are about twisting the knee, compressing the knee and twisting it. So they're McMurray's tests, Apley's tests, different twisting tests of the knee. And the patella test, really it's about checking for lateral instability of the patella. Yeah. So the patella apprehension test, like the name implies, when you start to push the patella laterally, the patient is very apprehensive about it. They don't like you doing it. So you have to exercise a lot of caution with that test. So there's some of the basic tests, special ligament tests for the stability of the knee. All right. So the management, whether that person needs to have a reconstruction or not, depends on a lot of factors. We already said the ACL won't heal. So the ACL will basically just dissolve, and that person may or may not have an instability of the knee. The instability is usually in pivoting, a rotary instability. So it's when not usually when they're walking in a straight line, but when they change direction, the knee can just give way. Now some people have got an ACL deficient knee, but their muscles are good enough and their control is good enough and the knee doesn't give way. And those people are defined as a coper. They can cope with the instability. Other people have got just a minor injury or whatever and their knee's giving way all the time. So they're a non-coper. There are some people in between who are avoiders, who alter the way they move or alter what they do to avoid a situation where the knee might give way. So they're kind of in between. But what I'm trying to tell you is not everyone who has a ruptured ACL needs to have surgery. They don't all need to have a knee reconstruction. It depends who they are, how old they are, what are the consequences of going through that general anaesthetic, the risks involved in that, and the risks of complication after the operation, versus, how bad is the knee? Like, how bad is the instability? And like I said, you've got people who've got an ACL deficient knee, they've been working or playing sport for years and they didn't even know they had a ruptured ACL. So there's that. There's a lot of factors